uh, to our Association for Pulmonary Critical Care and Sleep Medicine Division Director fall webinar. The topic of this webinar was really prompted by a survey that we did for the membership, and the number one topic that they would like us wanted us to address is business and medicine. In discussion at the executive committee, uh, we came up with billing and coding as one of the most important one, and develop a discussion and who we invite and what do you focus on. And I'm going to pass it on to my colleague who is also on the executive committee, Sai Parasarthi. And Sai, would you please introduce the topic and the speaker?
Absolutely. It's our absolute pleasure to welcome Dr. Scott Manaker to give us talk on to bill or not to bill in critical care, mistakes and solutions. So this is going to be focused on the critical care space, and it's apropos for me to introduce Dr. Manaker, who's an actively practicing pulmonary and critical care physician at the Pulmonary and Critical Care Division at the University of Pennsylvania in Philadelphia, where he's also a professor of medicine and physician advisor to Penn Medicine Office of Billing Compliance. He doesn't, need introduction. He's well known in the circles, including the American Thoracic Society, American College of Chest Physicians, and the American College of Physicians. And he also, at the American Medical Association Relative Value Unit, or RVU Update Committee, or RUC as it is called, where he's served in the past. He currently chairs the RUC Practice Expense Subcommittee for the AMA. Dr. Manaker serves on the Novita Solutions Medicare Contractor Advisory Committee for Pennsylvania and was appointed to his fourth term on the Center for Medicare Medicaid Services Hospital Outpatient Panel, or HOP, on Ambulatory Payment Classification Groups, a federal advisory committee to the CMS. Dr. Manaker lectures widely across the United States as a physician advocate, speaking on chart documentation, billing, coding, reimbursement topics, including teaching physicians regulations, critical care, evaluation and management coding, consultation policies, non-physician providers, and the impact on electronic medical records. And so without much ado, I will hand off these slides to Dr. Manaker so that he can take it from here. Take it away, Scott.
Thank you very much, Sai. So I'm really honored to have been give this talk. And as Sai mentioned, and Nizar, there's a lot of interest in billing and coding. And so we had a long talk about what we should focus on, because there were about requests for about 8 or 9 hours of material. And we decided we would start with critical care. There was the most interest in that. So in the survey that Lauren will be circulating a little bit later today, please select what topics you might like for an additional webinar, which could be on working with advanced practitioners. Lots of details there to go through. We could talk about medical decision-making or time for billing hospital or office visits, which would be another great topic. Or we could talk about the importance of diagnosis coding, largely for hospital and health system reimbursement, but increasingly, now that 80% of us are working in the company store for one or another entity as employed physicians, that winds up being how we get paid. So we can have a whole session on the importance and relevance of diagnosis coding. So when you're doing the evaluations, let Laura know if you want another talk on E&M coding, on working with advanced practitioners, or diagnosis coding. So with that as an introduction, I'm going to go ahead and get started. I'll remind everyone to please mute your microphones, but please unmute your microphones and interrupt me. I've given hundreds of webinar talks like this on billing. I'm well used to being interrupted, and I'm monitoring the time. We've got 90 minutes, so there's plenty of time for me to take questions during the talk. If for some reason you're shy, bashful, intimidated, and you put a question in the chat, I assure you Laura and Nizar will interrupt me on your behalf. But please don't be bashful. Just unmute and chime in. Again, I'm on way too many committees, largely dealing with physician reimbursement, but at times dealing with hospital and health system reimbursement. This is the usual disclaimer that I show whether or not people are getting CME. I do highlight I've been a consultant to RAND on a couple of occasions. They have a CMS contract to try and come up with a better allocation methodology for practice expense RVUs. As was mentioned, I chair the practice expense subcommittee of the RVU update committee, or RUC, for the AMA. That reminds me, if you're interested, I have another whole hour talk on the CPT and RUC process. If that's of interest to people, just let Lauren know afterward. I always give a lot of credit to my team of nurse coders, Carol, Mary, Sharon, and Annie, as well as Tanji, who supports us administratively, because if they weren't working hard, noses at the grindstone, I wouldn't have time to give lots of talks like this and go gallivanting around the country and give more talks and meet with people. So now to the meat of the talk. We're going to focus on critical care. This is the billing of critical care, both the initial hour and subsequent half hours for the past 15 years or so. And what you can see are the blue bars are the initial hour of critical care. And although they had been rising pretty steadily, 3 to 5% every year, year after year, as we do better keeping people alive for longer who are sicker and more immunosuppressed, and we have more and more technology, we clearly peaked in 2020 with COVID. And then for some reason that a number of critical care health service researchers and I have been trying to figure out, the amount of critical care billing seems to have gone down the past several years for that initial hour. What is hard to appreciate from this slide, but you can see, is there was a substantial drop of probably almost 10% in the subsequent half hours of critical care, the 99292. In calendar 2023, and that's because of the change in billing, 99292, not eligible until the 105th minute. I will show you the program memorandum that CMS sent to all the contractors saying, do this to your claims processing computers. And we'll talk about the impact of this on 99292. But you do have a sense that pretty consistently and it's been consistent for the past 30 years, the proportionality of 99291 to 99292 is about 10 to 1 in the Medicare fee-for-service program. For those of you division directors who are curious, what should my benchmark be? The benchmark in Vizient for academic health centers, it's more like 5 to 1 billing. Remember, this is the entire fee-for-service program over the whole country, lots of non-academic medical centers and physicians included. So a little more frequent in academic medical centers, probably reflecting the sickness and intensity of who is billing critical care. Now, I'm going to be going over some basics just so we have a level playing field fairly quickly. Again, interrupt me, unmute and interrupt me if I'm going too fast. And then we'll go through lots of notes, live notes from largely the Epic system. I think I've got a couple from some other systems along the way as well. And they'll be HIPAA redacted, so you don't need to worry about that. Some of them are actually my notes, and you'll see my name on them. Some are from both Penn and various other places around the country, as people have actively shared notes with me. Now, you can see over the past 25 years, the proportion and who is billing critical care has fundamentally changed. The yellow wedge is the emergency room. It has tripled over these 25 years, and the ED docs are the most highly audited of physicians billing critical care. But what has really exploded over the past 2 years is that huge orange wedge in 2023 of advanced practitioners, both NPs and PAs, who are now billing almost a quarter of all the critical care in the US. And we'll talk a little bit about that a little later on. That orange wedge was not present in 1998 because it was the Balanced Budget Act of 1998, which first allowed advanced practitioners to practice independently and drop bills for their services. You can also see that the amount of critical care has about quadrupled over these 25 years. And there are a number of specialties billing small levels like infectious disease and nephrology who do bill critical care. I'm going to show you a pair of infectious disease notes because I'm sure many of you are saying, how the hell can ID docs bill critical care? And I'm going to show you a pair of notes that were reviewed by the OIG when we get to it. I hadn't planned on talking about renal very much, but if any of you have folks who are critical care nephrologists, as we do, I will help just ask the question, and I will explain to you, as I've explained to our critical care nephrologists, why they don't want to be billing critical care for all their CVVH in all the ICUs. If you're billing lots of critical care, you should expect to be audited. It is part and parcel of practicing medicine in the 21st century. There were a whole bunch of critical care audits going on all across the country until COVID hit, when everything came to a screeching halt. And the reason there have always been lots of critical care audits is because it is the most highly paid at 4.5 work RVUs of any of the evaluation and management services. So it makes critical care a big target. This is a representative physician intimidation letter. I'm sure some, if not all of you, have seen letters like this. So when we get them in medicine here, usually someone in a panicked mode faxes or sends a scan of their letter, and I just anonymize it and make a slide of it and show it in that year's billing compliance talks until I get my letter, and then I show it just like this one. And this is a standard physician intimidation letter. Dear doctor, you're billing too much, whether it's office visits, hospital visits that are high complexity or critical care. You're billing too much for our standards, and if you keep it up, we're going to come audit you. And I always reassure our faculty, we spend all this time educating, training, providing tools and tips and tricks so that you can properly document the medically necessary high complexity services that you provide, including critical care. So my response to the auditors is bring it on. We will bury you in paper. And so what you can see here is I got the routine letter comparing my critical care billing to that of the average pulmonologist in Pennsylvania. Well, Penn is like the third largest solid organ transplant place in the country. We've got a huge bone marrow transplant program where the place where CAR T-cell therapy was founded. Where are you going to find more critically ill patients? Of course, all of us and most of the pulmonary division got letters like this. All of us are going to be outliers compared to a standard of a community-based average pulmonary and critical care physician for the amount of critical care that we bill. So if your faculty get letters like this, take a look at a couple of their notes. feel good that they're properly documenting, and then tell them, don't worry about the letters, bring it on. If you are audited by Medicare or the OIG, at least they give you their standard checklist. When you are audited by for hospital visits, for office visits, for your pulmonary function billing, you don't get a little checklist like this, which says what exactly they're looking for. And the 5 arrows point to the key points, which really coalesce to 3 key features, which I will emphasize in the next to last slide of the deck for billing critical care. The 3 required features are: how much time did you spend doing what? What was your critical care service for what critical care diagnosis? How much time did you spend doing what for this diagnosis? And they come right out and they tell you what they are looking for. I'm going to spend just a quick moment laying the ground for what is the definition of critical care. It's right here in 2022. As part of that memorandum to the contractors, Medicare adopted the CPT definition, which had been in effect for many years, and it's a critical illness or injury acutely impairs vital organ systems such that there's a high probability of imminent deterioration. And I want to emphasize that sentence because it says a critical illness or injury acutely impairs, so there's a high probability. In other words, you are already critically ill. It is not sufficient to simply be at high risk for something to be bad. Something already has to have gone wrong, and you have to have respiratory failure, renal failure, hemodynamic circulatory failure, kidney failure, liver failure, CNS failure with coma or encephalopathy, metabolic derangements. But you have to be critically ill, which intrinsically has a high risk of further deteriorations. And I'm going to show you a couple of examples from live chart notes to drive that point home a little bit later. Another key thing, particularly in this era where hospital visits, office visits, telemedicine visits can be time-based and can be anywhere during the 24 hours, calendar midnight to calendar midnight. Critical care is still time-based on the floor or unit. So people have inappropriately started trying to include time that they're not in the ICU or on the unit. There are operational definitions of on the floor or on the unit. The operational definition that we use is on the floor or unit means you're not separated by an elevator or a stairwell. You might stick your head out from the room and say help, and if you yell loud enough, it can echo down 2 city blocks long if there is an uninterrupted corridor without an elevator or a stairwell that somebody can come help you. But if you're having your family meeting in the chapel or in a nice patient and guest relations conference room or somewhere off the floor of the ICU, you cannot include that family meeting time. You cannot include the discussions with pathologists, radiologists, other consultants need to be on the floor, but you can be looking at the images in the packs, pulling up the labs, getting the history from whoever. A bunch of things are bundled into critical care, and you don't have to worry about those. These are the big ones that are separately billable, and you'll see some examples. You need to separate the time for each of these other services, even if for whatever reason you choose not to bill it. I'm often called, I won't bill for the A line. I'll just include it in my critical care time. No go. You've got to separate out the time for anything and everything that is billable, regardless of whether or not you drop a bill for it.
Hey, Scott.
Yeah.
Hey, it's Lynn. How are you?
Oh, great. It's great to have you with us.
Thank you. I have a question on your previous slide. You talked about chest X-ray. So does interpretation and review of the chest X-ray
Yes.
included? Okay.
Yes, all the time that you spend shooting thermal dilution cardiac outputs through the swan, looking at the imaging, looking at the labs, managing the vent, the time it takes you to draw a blood gas, and of course, all of the advanced care planning conversations that you would have, any of that and all of that, the clock is ticking. But it's got to be on the floor. You can't go down to radiology and look at the images. You can't go down to pathology and look at the histology. It's got to be on the floor unit.
Yeah, thank you.
Sure. Okay. When you have one of those other procedures that you're dropping a bill, you would normally add the 25 modifier to your E&M service, depending on what, which includes critical care. Depending on what your processes are, you need to make sure that your bills are being coordinated, because you don't want to go and bill for the A line today and then send your critical care bill out yesterday, the day before, without that 25 modifier, because they will not pay you for the procedure. You need to make sure that your 25 modifiers are coordinated with your critical care claims if there's going to be another procedure that's billed, A-line, central line, intubation, bronchoscopy, thoracentesis, whichever. The first hour of critical care is defined by CPT as few as 30 or as many as 74 minutes. Each of the subsequent half hours then kick in from 75 to 104, 105 to 134, and so forth, according to CPT and based on historical precedents going back 3 decades. Until someone at CMS made a mistake. And I'm going to tell you now that not only is this a mistake, I have said this is a mistake in meetings with CMS trying to get this fixed. And I have said this is a problem, this is a solution in search of a problem, and they can't tell me what the problem was. But in this program memorandum at the beginning of 2022, they said, and I'll read the underlined line to you. You can only report 99292 when you get to 104 minutes. So no longer at the 75th minute could we bill 99292, and that probably accounts for the 8-9% drop in the 99292s in calendar 2023. Now, they took that away, and recall a few slides ago, I reminded you that 99292 is 1 out of 10 in the Medicare fee-for-service program. It's a 1-to-5 ratio in Vizient for academic medical centers. Losing a proportion of the 99292s shouldn't be breaking the bank, but it definitely created a revenue problem for virtually every division chief or MICU director that I've spoken to, because every nickel counts. They did give us some other things, though, in exchange. So the first one is in the blue square. When someone starts providing critical care but doesn't meet that 30-minute minimum threshold for the hour, someone in the same specialty and group can push it over. That was not previously true. You couldn't bill critical care until the first individual met that 30-minute threshold. A second thing that they gave us later on in this memorandum was that different specialties could now overlap minutes. So when I show you my conversation with the surgeon at the bedside for abdominal compartment syndrome, at that time, we had to have no overlapping minutes. And I'll show you that note a little later on in the context of what late addenda on the same day can look like in the chart. So the impact of this godforsaken memorandum is that you can't bill that subsequent half hour until you complete 104 minutes of critical care, or multiple providers of the same specialty and the same provider group hit that threshold, because the substantive portion of the service still remains based on time and not who's doing the majority of the decision making. So what happens when you're working with advanced practitioners? If the APP sees the patient first and you come by and see the patient second and you both spend 35 minutes, the APP has triggered that first hour and you don't get to bill any additional critical care time because you haven't reached the 104th minute. In the second example, the APP gets to bill the first hour and you, the physician, gets to bill the subsequent half hour because you've gone past that 104-minute threshold. But in the third and fourth examples, you haven't gone past the threshold, so the physician doesn't get to bill that subsequent half hour. And then you can see both the physician and the APP get to bill for that last example, which is 130 minutes, but it's still only 1 unit of 99292 compared to prior years before the memorandum when it would have been 2 units of 99292. And we can talk about the politics of this a little bit later on in the discussion and Q&A at the end, if you like. All right. Now, as I mentioned a few minutes earlier, right, time on the unit or at the nursing station, looking at the results, looking at the imaging studies, talking to the consultants come through, updating and talking to the family members about the medical decision-making, not a routine update, but here's what happened today and last night. Here are the decisions we're now considering. It's got to be relevant to the medical decision-making. All of that time counts on the floor or unit. So let's start looking at a whole bunch of notes. And again, these were picked. I have a wealth of notes accumulated over the years, but I picked some interesting and fun teaching examples. So compared to the copy and pasted, pulled forward crap, and I've gotten a couple of examples of that a little bit later on. This is my attestation. So the resident wrote whatever the resident note for this patient being admitted on April 16th. And at the end of the day, I went and saw the patient. And I actually examined them and talked to the resident and said, okay, here's the plan. I'm going home. I'll write my attestation. I'll write my note in the morning. And the key features are the bottom couple lines where I say I spent 35 minutes of critical care time on the floor on April 16th. And my note was delayed to the 17th. And that time for writing this note on the 17th is not included in my 35 minutes for April 16th. So it's crystal clear what I did here and when I did it and where the billing should go. This is a problem all the time when physicians are working with advanced practitioners. If we do a session on advanced practitioners, I've got lots of examples to show you. The attendings coming in on Tuesday, the advanced practitioner admits the patient on Monday. They write an attestation thinking this is a split shared service, and they're going to get the admission note. And that's wrong. The admission note gets billed to the advanced practitioner on Monday because under the split shared regs, you need to see the patient on the same day. Now, here's an example at the other end, which is not critical care. It's got a laundry list of history at the top, and it says continue assessment, continue monitoring, continue OG suction. What in the world did this physician, this surgical intensivist, do for the lowermost red arrow shows 120 minutes? What did they do for what diagnosis? Continue an esmolol drip? So when I used this slide for the first time and the surgical intensivist happened to be in the audience, let me tell you, she came up to me at the end of the talk, and if she had a scalpel in her hand, I would not be here today because she would have decapitated me. And she just starts yelling about this post-op heart patient who suddenly starts gushing blood from their chest tube, and she's calling the CT surgeon back, doing massive transfusion, opening the chest, doing open cardiac massage. And when she was done yelling, I said, if you had written any of that in the note, it would have been clear. But you get paid for what you write in the note, not what you do. And your note doesn't say any of that. So the note has to reflect good patient care, what you did for the patient, and what you should appropriately be paid for. Because if you do God's work, but you don't have it in your note, you're not going to get credit for it. You do not need to physically examine the patient. And there's a very famous intensivist who, I'm not going to say their name because you'd recognize them, who used to do ICU rounds from the doorway, because with the invasive monitoring and seeing what the ventilator was doing and having looked at the imaging in the labs, he could manage anybody who was critically ill. He found the physical examination did not substantively add to his care of the patients. And what you can see here is I've got a short paragraph, 2 short paragraphs about what happened, right? Multiple arrests overnight. They've got a pacer. They're on the circuit. They're fully ventilated. They're on 4 pressors. And we kept everything going till the family could get there, and we withdrew care. I didn't document any physical exam. This was a COVID patient. And this was, perfectly fine for billing critical care with an absent physical examination. It says exactly what I did for exactly how long. Got multiple critical care diagnoses, multiple critical care services, and it was a decent note. Now, most of the patients we take care of have sufficient diagnoses for lots of people to be providing critical care. This is an acute liver patient. They've got enough diagnoses for what's wrong with them. For the intensivist, the nephrologist, the hepatologist, the hematologist, and the neurologist, all to be billing critical care on the same day. But they need to have a different primary diagnosis. And if you're a division chief, you need to really understand the processes for who's putting what diagnosis first on the bills. Because if all 3 or 4 specialties put acute liver failure as their primary diagnosis, it's only the first claim who's going to get paid. Everyone else is going to be denied because no payer is going to pay multiple physicians of different specialties for the same one diagnosis. Simplifying this, if pneumonia is the primary diagnosis on the bill for the hospitalist, the infectious disease physician, and the pulmonary consultant, only the first of those 3 claims that hit the claims processing computer are going to be paid. Now, if one has pneumonia and one has hypoxemia and one has pneumococcal bacteremia, now you have 3 clean claims, all of which will be paid. So if your processes at your institution are such that nobody's coordinating the diagnoses, you need to have conversations to make sure that the consultants are not using the same diagnoses that you are and getting their bills in first. at places like mine where we have inpatient abstractors who do the billing, they take care of all that diagnosis coding, as well as coordinating the correct modifiers and coordinating the timing of the claims when procedures like intubation, A-line, central line, thoracentesis, bronchoscopy are performed on the same day. And here's an example. Remember, with diagnoses, you're painting a picture for the claims processing computer of how sick the patient is and what you're doing for them. So here you can immediately see that the intensivist is managing the ventilator in this patient with pseudomonal sepsis and a baseline creatinine of 3. The ID doc is dealing with the pseudomonal sepsis and trying to decide, am I going to give Azactam or am I going to give an aminoglycoside? And then the nephrologist is coming along and saying, for God's sake, give him the Azactam so I don't have to dialyze him. We don't have to box his kidneys. The same patient is going to have the same diagnoses, but you need to cycle the diagnoses for your specialty's primary perspective and contribution to that patient's care. Now, I did emphasize earlier the patient has to be.
I have a question. This is Dan Fine at Montefiore. With regards to the diagnoses, are these specific to the diagnoses that you're putting in your documentation, or many of us, not all of us, put diagnoses in the EMR to bill ourselves? So which matters more for this particular instance?
The list of diagnoses in a problem list is medical history, and you wouldn't get any credit for it. The diagnoses that are relevant are going to be the diagnoses that are in your management. Now, you'll see some examples a little bit later on of what's more typically a SICU rather than a MICU approach, right, head to toes. Every patient starts with neuro, then lungs, then heart, then belly, then kidney, and so forth. That's fine, but if you're the nephrologist or you're managing the renal problems, your renal section, it might be 5th or 6th in line, but that's got to be the meat of what you're doing for that patient with a renal diagnosis. Does that make sense? Is that helpful?
Yeah, so it's what's in your note in the plan part of your note. Exactly.
Yeah. Okay. As the 2 hours titrating an esmolol drip showed, there was a problem list at the top, right? But you'd have no idea that the intensivist was managing a leaking repair of an aortic aneurysm from that note. By the way, I love Montefiore. I grew up a few blocks away and spent high school and my college summers working in a lab there. So.
Oh, awesome! Thanks for mentioning.
Small world.
Yeah.
All right. So, moving on. I emphasized I'm going to see some examples of patients who are not critically ill. So here's a patient transferred to HUP for management, and he had a big GI bleed, and he's sent here, trying to figure out where's he bleeding from. We can't figure it out. We're going to send him to the big academic hospital. Well, right now he's hemodynamically stable. If you look at his physical exam, he's got totally stable vital signs. He's got a completely benign exam with a benign abdomen, and his hemoglobin's 8.3. And the note of what you're managing for his GI bleed is you're continuing a PPI drip, and you come right out and say he's not in shock. So what the hell did you do for 75 minutes? And this patient is not critically ill. And it's not just the SICU. There are a lot of MICUs around this country where somebody transferred because a patient's, the referring hospitalist is worried, or they're there for monitoring because they might go south. You got to remember that definition. They're already critically ill, which puts them at risk. This patient is not critically ill. And we've got some surgical and ED examples coming up later on. Here's another one. People say, all right, somebody who's on the vent at night, they're critically ill because they have respiratory failure. Well, if they're on the vent at night because you're actively weaning them from respiratory failure, yes, you can make a very rational argument they're still critically ill. But when they're 97 years old and they get some nocturnal ventilation chronically, and they're sitting up in the chair on a trach collar because that's their normal daily situation, just like a multitude of patients at LTACs all across the country, they're not critically ill. You can't say they have severe sepsis if they're well perfused and they're getting empiric antibiotics and they have stable vital signs. They don't even have a tracheobronchitis. Maybe it's a tracheobronchitis. So just because the patient's in the ICU doesn't mean they are critically ill. Just because the patient is mechanically ventilated. We all have lots of patients with neuromuscular diseases who are chronically ventilated all of the day, most of the day, some of the day, and when they get admitted for their latest round of a UTI or even urosepsis, they come to the MICU because of their nighttime ventilatory needs, not because they are critically ill. And this is the kind of stuff that gets caught when people are audited for critical care. Yeah.
Could we say that in this particular instance, when they go on nighttime ventilation, that they are ventilator dependent, like use the Z99.11?
Just think about all those patients at LTACs and all those patients on home ventilation. They're on their home vent settings. How can you say they're critically ill with respiratory failure when they're on their home vent settings?
Got it.
And Scott,
right? Yeah.
For the question for your GI bleeder, if let's say your patient gets transferred to your ICU because they presented to the outside hospital with a GI bleed, they come in, they're not GI bleeding, however, now they are tachycardic and you're concerned about a recurrent GI bleed.
Okay, so they're at risk, but are they tachycardic because they've just been transferred? Are they tachycardic because they're actively bleeding? If they're tachycardic and they haven't yorked up a half pint of blood and they're not having melena, it's hard to say what that tachycardia is from, right?
Right. So, but if they've just been, is there
so the diagnosis is tachycardia,
Yeah.
not that they're critically ill, and there are lots of people with tachycardia who are not critically ill.
So,
Okay.
so could you say that they're actively bleeding and you're doing fluid resuscitation?
Well, only if they're actively bleeding. So if blood's coming out some orifice and their hemoglobin's dropping, okay, they're actively bleeding. Yes, upper GI bleeds, lower GI bleeds, hemodynamic instability, tachycardia, that makes you critically ill. But if somebody's got a lower GI bleed and goes to the MICU because the ED doc or the hospitalists turn them down because the hemoglobin went from 10 to 8 and they want to make sure they're stable and not continuing to drop and don't need a massive transfusion protocol, that patient's not critically ill. That patient's being sent to the MICU for monitoring, for observation. Because remember, when somebody's going to come through and audit you, you're not going to have me. I would be your worst nightmare on the other side, right? But you're going to have someone who knows what they're doing, who has seen a lot and may have been an intensivist in an earlier life, not just nurses reviewing the notes by the time you're getting in an audit and you as a division chief are being called to try and justify the notes.
Scott, can I ask you a question?
Sure.
Thanks for doing this, by the way. I'm Erhan from University of Minnesota. Let's say admitting this GI bleeder or other patients from the ED, and ED physician already built for critical care, in a different floor and comes to your floor. Can you bill that patient?
Yes, there are that's a perfect example. The ED doc bills for critical care earlier in the day. You're going to bill later in the same calendar day, midnight to midnight, but you need to make sure you have a different diagnosis from that ED doc. It's taken care of for us in our particular practice situation. But if that ED doc says, lower GI bleed, you need to have hypotension or blood loss anemia or diverticulitis as your primary diagnosis, because if the claims processing computer sees 2 lower GI bleeds, they're going to only pay the first claim that gets in. Now, if you get your claim in before the ED doc, you'll get paid and they won't. But you got to figure out the diagnosis.
Got it. Thank you.
All right. This is another very common question that I get asked. How about our DKAers? So this was actually caught in the 150 charts when we had our OIG audit back in 2019, right before COVID hit. So they came and they looked at 150 charts, and I'll show you some more examples in a little bit. And this patient happened to be admitted to the neuro ICU because they had recently had a mass resected and the path was pending. So they went into DKA on the neurosurgery floor and they went to the neuro ICU. And the physician billed this as critical care, the neurointensivist, because the patient was being converted from a insulin drip to aspart. And the OIG said, "Are you kidding me? Your note is mostly grayed out because it's copy and pasted crap. They came off the insulin drip overnight, and what little you added to this note says, quote, transfer to the ward for continued care soon. This patient is not critically ill." And folks say, well, you know, patients who come in with authentic DKA, they can be really sick. I say, yes, they can be really sick. They can have life-threatening critical illnesses like hypokalemia, severe metabolic acidosis, acute renal failure, hypomagnesemia. But you've got to say that in your note, not DKA, titrate the drip. And Haley Gershengorn has this wonderful article in Critical Care Medicine where she looked at thousands and thousands of DKA patients admitted in New York State, either to the ICU or to the floor, who received insulin drips, and no difference in outcomes. And why is that? Because a patient with DKA going to the ICU is going there for nursing reasons. It's whether or not you have the nurse staffing to keep changing the IV fluids every 2 hours, and the supplements with the potassium and the magnesium and maybe the phosphate, and maybe push a little bit of bicarb in there, and recheck finger sticks every hour and BMPs every 2 or every 4 hours. Some nursing floors can't handle that. It's a nursing issue whether they go to the ICU for an insulin drip. And at our own institution, over my 30 years, it's fluctuated. Some years, yes, some years, no, depending on nursing staffing. But if your note talks about the life-threatening metabolic and electrolyte abnormalities, now you're talking. But not just because they're on an insulin drip. Now, how about infectious diseases, right? As the pie charts at the beginning showed, about 1%, less than 1% of the claims for critical care billing are from infectious disease or from nephrology. So I have a pair of ID notes here for your consideration because they're 2 sequential days, both caught up in our OIG office. So this is a patient in the SICU. And this ID doc says it's fine to continue the VORI, but we're going to change the Zosyn to cefepime and keep doing local care, and has a nice physical exam. And this patient has multiple toe amputations and says, I looked at the labs and we're going to continue monitoring for toxicity from these meds. And we've adjusted some of them. Well, this is a subsequent hospital visit. He doesn't say the patient's critically ill. There's no critical care service here dedicated to a critical illness. Now, when the OIG came and looked at the 150 charts and 150 critical care notes, they denied about 15 of them. And I was asked to look at all 15. And I actually agreed with all 15. They didn't meet the criteria for critical care. I actually think I know who the physician on working for the OIG was. But I think they did a very good job, and they denied this note. Contrast this note with the next one, and I forgot to mention earlier, Lauren has a PDF of the slides, so you don't need to be making screenshots. You don't need to be snagging any of the information. She can send you the slide deck, and of course, you can always reach out to me with any questions in the future. So this was Sunday, and of course, change of service on Monday. So a new ID doc comes the next day, and now you start getting a better sense of what this patient is critically ill with. They had a left radical vulvectomy. They had a flap dehiscence. They've had acute on chronic renal failure. They've got a pseudomonal UTI. Then they can develop respiratory failure, and it's unclear if it's from aspiration or a fungal pneumonia or alveolar hemorrhage or pulmonary edema from volume overload. And they're getting cefepime for their aspiration. She completed antibiotics. She completed pulse steroids for the DAH. And the one critical sentence now follows. I doubt infection is driving her current critical illness. She says the patient is critically ill. Which critical illness do you want? Diffuse alveolar hemorrhage, aspiration pneumonia, vent-dependent respiratory failure? There's a fistful of critical diagnoses here. She says what we're going to do with the antibiotics, and we're going to monitor for toxicity like her predecessor the day before. But this one sentence, I doubt infection is driving her current critical illness, is what makes this note billable and the prior one not. And I should say that the pulmonary consult team was seeing this patient on both days, billing critical care, which was approved on both days, and the surgical intensivist seeing the patient had their critical care approved on both days. So at the end of the day, we might be toiling in the Lord's fields, doing God's work, saving our patients. But if it's not in the note, we don't get paid for the life-saving God's work that we do.
Scott, so if there are multiple providers, in this case, surgery, pulmonary, critical care, and ID, billing for critical care, is it your recommendation that the more people who bill critical care, there's more likelihood of these notes running into each other and one of those critical care charges
That is true, and the McKesson claims processing software that all payers use have a variety of toggle switches, flags, that they can set. So sometimes it's more than 2 hours or 3 hours of critical care on a day. Sometimes it's an initial hour of critical care from three or more different providers, where they may say, we're not going to pay, we're going to do a prepayment audit. Please send us the notes for review. But again, I say, that's all right, we'll bury you with paper. You're just slowing up on the AR. It's going to be a delay in payment to process the paper, get it to you, and then you make a decision and pay us back. But at the end of the day, you're going to pay us because the notes are there. If, on the other hand, they get 3 different claims for 3 hours of critical care, totaling 9 hours, they're going to have a rationale for saying, we'd like to see the notes before we start paying this. The problem is it is up to each individual payer where they set their flags. And so it's really hard to predict. But you can just... you can think empirically about it. The more critical care gets billed for the same patient on the same day, the more likely a payer is going to ask to see the notes. Does that make sense?
Yes. Dr. Sinner has a question.
Oh, go ahead.
Hey, Scott, how are you?
Good.
So We do not that many consults outside of our ICU. A lot of our ICUs don't call us, but we follow in some of the units. I try and make the distinction, maybe a little artificial, around a consult and sort of critical care management. And that may be sort of artificial because it's really going, but you're supposed to be a little managing something. So if you say change the antibiotics for an ID doc, is that sufficient to really be critical care? They're obviously critically ill, but it's sort of advice. Whereas at least when we're on our home base, I'm the one changing the ventilator essentially, or my team is. We're actually
Yeah.
doing it. So I don't know. I'm just trying to be a little more. You're giving a little more leeway probably to what I was giving
Yes.
to my faculty,
Yeah.
but
Yeah. Yeah. I think it's a great question. And really you're asking, what is the essence of a critical care service? Is changing the antibiotics based on the sensitivities sufficient? I would say no. Is changing the anti-infectives in the context of multi-organ system failure here, lungs, kidneys? Yes, I would say yes here, because I got two organ systems which are really problematic. If I don't treat this infection in the lung correctly, they're gonna drown in massive hemoptysis. If I don't choose my antibiotics right, I'm gonna box the kidneys, which have already had an episode of acute on chronic kidney failure. But you're right. If it was simple pneumococcal sepsis and the sensitivities have come back and we can narrow to penicillin or augmentin instead of cefepime, I would agree with you. That's not really a critical care service.
okay.
But
Does that make sense?
I think what you're asking is, as a consultant, you can make all the recommendations you want, but the primary team still may not do it. So can you still bill critical care for recommending changes in the management that may or may not get implemented by the primary team?
Yes. Yes. You're providing, when you're providing critical care, you're providing a service. And the service to that patient is, if you're the consultant, providing the best advice to the attending. If they're free to take or leave your advice, but if you are providing a critical care service in recommending, in this setting, changing anti-infectives for multi-organ system failure, in a variety of other settings, recommending ventilator changes that the anesthesia intensivist or surgical intensivist doesn't take your advice, that's on them, not you. You've provided a critical care service in making those vent recommendations.
Scott, we talked about different specialties billing critical care.
Yes.
What happens if the physicians are from the same division, let's say?
Then you can bill critical care, but it's supposed to be aggregated and billed under the name of a single physician. So if I provide an hour of critical care in the morning, or let's say I'm the overnight person, and I provide an hour of critical care at 2:00 in the morning, and then I go home because you come in on the day shift and you round with the team and you hear the story and everything's hunky-dory, you can't bill any critical care because you haven't done anything. You haven't provided any service. If, on the other hand, based on what's happened between 2 a.m. when I admitted the patient and wrote my note, and 9 or 10 a.m. when you're coming by with the team, and you're changing the pressors for more or less hypotension, you're changing the ventilator settings for changes in compliance or oxygenation, you're changing the fluids and electrolytes for worsening creatinine, you can add your critical care time for making those changes. But you've got to have changes and actually be providing a service. And so if you do another 2 hours on top of my hour, now we can bill 3 hours of critical care. But either I get the 3 hours or you get the 3 hours. We can't bill 1 hour for me and 2 hours for you. So that, as a division chief and really as an institution, you got to make some decisions. Do you give it to the person who's the ICU attending? Do you give it to the person who bills the most critical care? Do you give it to the first pig at the trough who gets to eat?
Yeah.
Those are all administrative decisions for how you want to run your processes. All of them are legitimate. Depending on how your divisions are run, there are more or less equitable ways of dealing with it. If you're always giving it to the person who does more critical care time, over the course of a year, that will probably even out. If you're always giving it to the MICU attendings and everybody is doing their fair share of nights, that's fine. Or if the night people are supported by hospital payments or health system payments, they're not earning their salary based on nighttime RVUs. Give it all to the daytime people. It really depends on what your local processes are.
Yeah, no, thanks for clarifying. So my question is, what if there are 3 pulmonologists, one from interventional pulmonary, one from transplant pulmonary, and one general pulmonary, and they are seeing the same patient with different reasons? Can they bill critical care separately?
No, because they're all in the same division. They're all in the same provider group.
Okay, thank you.
Dr. Chang?
Hey, George.
Hi, Scott. Thank you for the information. Question for you: If in some of the taxonomies for each of the providers, some of us are sleep critical care, some of us are can you clarify that?
Sure. There's over 600, almost 700 different taxonomies. So I'm going to do neurology because the stroke neurologists have a different taxonomy than the neurointensivists. But at the end of the day, nobody cares about what your taxonomy is. It's only about 100 specialties, enrollment specialties. And both of those neurologists, the stroke neurologist and the neurointensivist, taking care of the same patient, but they're both neurologists. So only one gets to bill critical care for the day. They can merge their time, but there's only one because taxonomies don't count. People say, well, how about cardiology? You've got EP and you've got cath, and now you got heart failure, heart transplant. Yes, but they now have different enrollment specialties. It's not about taxonomy. It's about enrollment specialties. And if you have enough physicians, you can go and separate them. So like our EP cardiologists are a completely different provider group than our heart failure transplant cardiologists, who are a completely different provider group from the cath lab cardiologists, who are a completely different provider group from the clinical cardiologists, because they have 4 different enrollment specialties. But there's critical mass of all of them, so there are no issues about cross coverage. If you have fewer physicians and you are cross-covering, then you run the risk of getting into a whole bunch of complications for cross-covering more days and having the appropriate modifiers and so forth, because you're physicians of different specialties, in essence.
Great, thanks, Scott. Just want to go back to that scenario where you have a hospital-employed nighttime pulmonary critical care physician, and then you have a daytime pulmonary critical care physician who's going to show up the next morning at 7 a.m. But the admission, let's say, happened before midnight. Let's say it happens at 8 p.m. A lot of these admissions happen at that time. So they write a note, they put their critical care billing and whatnot. But then when the morning person comes, even, though let's say there's not much of a change in the plan, but they provide the critical care services, make adjustments to the ventilator, make adjustments to the pressor. They're both from the same division. So they should be independently freestanding. They're not going to get collapsed or collated into one provider. Is that right?
That is right. I'll simplify it for you. The nighttime person does the admission at 8 o'clock and says they did an hour of critical care, and then midnight strikes. It's time midnight to midnight. So the next morning, the daytime person comes in and says, you know, Sai did a great job last night. I'm not changing a thing. The patient's stable and getting better, but they're still critically ill, and we're titrating down the pressors and coming down on the PEEP. Everything's getting better according to Sai's plan from last night, because you don't have to make any changes. Your service can be continuing the same for this patient who's critically ill. Managing the vent, the pressors, the fluids and electrolytes, the anti-infectives. We're not making any changes to the plan. That's a legitimate hour of critical care, even though you made no changes, because it's a different calendar day.
Great. Thank you. You answered my question. Gary Ewart has a question in the chat regarding family discussions used for critical care time.
Yes. Yeah. Well, Gary, you're shy. You can't unmute. So the family discussions, as long as they are on the floor or unit and dedicated to medical decision making, all of that time counts, and it counts as critical care minutes, which are paid a lot higher than advanced care planning minutes, which is what you would use for a floor or office patient.
So, Scott, if I understood Gary's point, is that does the family also has to be on the floor, or you can be on the floor calling the family from there?
Oh, you could be on the floor calling the family. That's just fine.
Yeah, I think that's the point.
You need to be on the floor.
Yeah,
the family could be anywhere.
Exactly. And I think that's his point.
Yep. And in fact, we've made sure to have adequate touchdown space for the attendings on the floor in the ICU. A lot of them would like to go back to their offices elsewhere, separated by an elevator or a stairwell. Then they can't include the time for typing and writing their notes. So we've got touchdown space for them.
So just a time check. We have 21 more minutes, but I wanted to make sure, Scott, that we get to at your pace. There's going to be multiple of these, is what our expectation is. But want to understand the split billing between the APP and the critical care physician at your own sweet time.
All right, let me try and finish up, and then we'll talk about working with APPs in a little more depth. Just a reminder that as you're thinking about and building your notes, think of them as a toolbox and various pieces that you can insert or delete, rather than having what most people do is one standard template that everybody uses and nobody changes. And that's why everybody's billing 35 minutes critical care time for people who are no longer critically ill and going out of the unit. And each of these are individual parts that you can include or delete. Our division has gone and created a bunch of these smart phrases. These are my personal smart phrases that I made with lots of triple asterisk wildcards, which is what works in the Epic system. If you've got Cerner or now Oracle, there are different ways, but it makes me stop and think so that it is very specific to this patient. In contrast, the division, and I don't use any of these, they've got all of these standard slap-ons for a variety of critical care illnesses. But the important thing is that you have those wild cards that make you think what's different and special about this patient from the rest. I've got different macros for different settings. So the baseline physical exam that I start with and then modify to make it patient specific in our LTAC is very different than what I have for the ICU. I'm going to quickly go through these rapid response questions because I want to have time to show a couple of patients who were not critically ill and also talk about copy and paste. So you lead the rapid response, you provide a resuscitation lasting 8 minutes, and then 70 minutes of critical care while they're clearing the bed and taking the patient to the ICU. And so, yes, you can bill critical care and you can bill CPR for that 8-minute resuscitation. There's a separate CPT code. It was in the earlier slide of things that are separately billable. You would add that 25 modifier to your note. And here's what it looks like. I came in and the patient coded after we supinated them from having been proned overnight. We gave TPA, prolonged resuscitation. They still died. I said I titrated the norepi and the vasopressin for their hypotension. And then you can see my note, I went and added to the attestation that in parentheses, doesn't include bedside procedures, including the unsuccessful resuscitation to cue our fee abstractors. And in the bottom, I always type the CPT codes and I cue them to make sure they remember to put the 25 modifier on the critical care and they have the CPR. Then if you're the receiving physician, you provide another 30 minutes. They code again. The resuscitation is 28 minutes. You call the family and the organ procurement organization. You can't bill discharge day management because that's bundled into critical care. You can bill an hour of critical care for your initial 30 minutes, but once the patient dies, there's no longer any time that you can bill. You certainly haven't hit the 105th hour. The one exception to this is if the patient is declared brain dead and then becomes an organ donor and you are managing the donor, you can continue to accrue critical care time if you, rather than the organ procurement organization, is managing the patient, but that gets billed to the organ acquisition fund, not the patient's in-life insurer. This is another note where this was my patient in the ICU, transferred to the ICU, and then I was out of the ICU at a meeting. They coded. The rapid response team did respond. This was a remote COVID ICU at the time. My colleague wrote this note. I get back from my meeting. I learn of the code. I read the note, and I call my colleague and say, you got to fix your note. Because she says, I spent 70 minutes from 11:45 to 12:50. Well, you can do the math, and that's only 65 minutes. And the 15 minutes for the initial ROSC is CPR time, not critical care time. Then there's another ROSC for 25 minutes later on. So I called her up. I said, you got to fix your note. And so the next day she comes and she fixes the note. And she says, yeah, after the CPR time, it was only 30 minutes of critical care during those 65 minutes. And that's how she got her 30 minutes of critical care time and her CPR. This is the late day addendum I mentioned to you before, where the general surgeon and I are talking about the patient with abdominal compartment syndrome. I had written my note earlier in the day. I get called back. I just simply put the addendum at the bottom here saying I came back. I'm talking with the surgeon, and they're going to take her to the OR now. And you can see at the very bottom, I have 2 electronic signatures reflecting the addendum to the note. Back then, had the surgeon wanted to bill critical care time, they couldn't have. This was 2021 because I was taking those minutes. Now they can actually bill critical care time because surgery is a different specialty from pulmonary or intensivist. This is a cardiology note musing about the causes of shock. They were to the point of being a consultant. Here they're a consultant to a patient in shock. They're talking about the origins of the shock. They don't think to build critical care time, and they don't even put their time here. So their musings actually don't rate to high complexity medical decision making. They got a bunch of prescription medications here. None are being monitored for toxicity. There's a bunch of labs there, but there's no second high complexity medical decision making factor to get them to high complexities. This is a subsequent hospital level 2 99232, they clearly would have spent 30 or more minutes. Had they done that, our fee abstractors would have billed 30 minutes for a critical care hour. So here's the patient who drives himself to the ED and walks in and says, I've been shot. And the ED doc says, well, yeah, his shoulder hurts with a range of motion. There's no other entrance or exit wounds, just the gunshot entrance wound. We don't have a CT here, so I'm going to transfer them to the trauma center so they can get a CT. And they say total critical care time, 33 minutes. Okay, but is this patient critically ill? What did they do for 33 minutes for what is a flesh wound? And this ED doc screamed bloody murder, and I got called in to take a look at this note, and I just told him, look, the patient's not critically ill. If you said they can't move one of their fingers or they're numb in the palm of their hand and there's a potential neurovascular injury, now they're critically ill. But that's not what you say here. The note's got to reflect what the critical illness is and what your service is. Here's another. Yep, go ahead.
David Stoltz from Iowa. This idea of, putting sort of an exact number of minutes, 33 versus 35. Any thoughts on that?
Oh, yeah, it's a very common question. So in a community practice, right, you take care of one patient, then you move on to the next. It's easier to do start-stop time. For most of us in academic medical centers, it's very seriatim, right? You go and see the patients early by yourself. Then you go back and you get more history from the house staff, the RTs, and the RNs as you're rounding. Then you go back later in the day, finishing your notes. So it's bits and pieces of time. So you can do a time motion study and know it takes me this many minutes to look at the vent, this many minutes to examine the patient, this many minutes to talk to the RT and the nurse last night, because I personally get in at dawn and see the patients before 7 a.m., change of shift, this many minutes to round with the house staff. In general, it takes me 32, 35, 33, 37 minutes, whatever your routine is. And then when something deviates and you need to spend more time, you just separately track that additional time, and that gets you when it's 40 or 53 or however many additional minutes, because you've done something extra for that patient on their routine. I don't know anybody who has 13 stopwatches for the 13 one each for the 13 patients in their ICU.
I guess my main thought was is 5-minute increments, is that a red flag, or is putting these exact minutes more red flag, or does it even matter?
I don't think it matters if asked. And your answer is, that's my routine time for what I normally do for every patient. And that's why your routine time is 33 minutes. That surgical intensivist routine time is 32 minutes. Mine is 35 minutes. Somebody else's is 30 minutes flat. And there is some variation that way from what your routine is. And then we all vary when there's additional things for additional time. So again, this is a patient who was transferred preoperatively for peri-op monitoring. And it's just another example of critical illness. This is an example of a more typical SICU approach from head to toe. And you start reading through the note, they're well perfused, there's no edema, they're awake, they have a bunch of outpatient problems, including high blood pressure and hyperlipidemia. They've got a bowel obstruction, which they're treating medically with a PPI and advancing the clears. Their sugars are controlled. There's nothing wrong with this patient. And somehow the surgical intensivist says, I spent 32 minutes doing all this stuff, but there's nothing there. Here's another example. This is a patient with a big operation, and you can see everything is grayed out because there's nothing new. And there are no acute changes, is the little that's different with this note. There's no vent management. There's no discussions of anything other than some chest PT, and they're getting Ancef and vitamin K. There's no critical care service. This is another one where the patient was resuscitated and hemodynamically appropriate, and they're going to be resuming home Lasix. Again, not currently critically ill. Here's a patient that I saw in the middle of the night who may have occluded their fresh stent. And so they went back to the cath lab, and there's like 2 paragraphs. It's not page after page after page of copied and pasted, pulled forward historical crap that is not relevant. A reminder that the teaching physician can't attest just like hospital and office visit notes. You need to fulfill all the requirements, but it's the same 3 things. What was your time? What was your service for what critical care diagnosis? It's really not hard. So here's a great critical care note. I wrote this on the 19th because I saw the patient late in the afternoon of the 18th. I say we're going to do ventilatory support, we're going to diurese, and we're going to give antibiotics for this ripping open aortic dissection. And why didn't I bill critical care time? It's because I was rushing out of the hospital and I didn't hit the 30-minute threshold. Otherwise, I could have had 99291. And this is a perfectly legitimate minimalist attestation. We do have a cut and paste policy. Most people don't even know about it, much less read it. If you cut and paste it, you own it. So this is my little stop the madness slide. We don't give any credit for grayed out. If, on the other hand, you write pneumonia, day 3 of 7, continues Zosyn yesterday, and today you change the 3 to now it's day 4 of 7, you do get credit because you are paying attention and you're taking good care of that patient for that one problem. Oops. So this is a MICU note from one of my colleagues in 2019, and you can see all the black text tells you what's going on. They were determined not to be a lung transplant candidate since yesterday. Their ARDS is slowly resolving. They're off neuromuscular blockade, Flolan, and proning. We're continuing to wean and we're lowering the peak. By the way, we're out of shock from the pneumonia on Miro. They're paying attention. They're providing good care. Everybody participating knows what's wrong with this patient and how they're doing. This makes me pee in my pants in terror because this is the house staff note for this patient on this day. And the only thing that's new here is for some reason they typed analgesia for weaning the fentanyl, and we're going to be giving IV colistin. They have no idea. You have no idea what's actually wrong with this patient. And it terrifies me because as I grow older, these are the people who are going to be taking care of me, for God's sake. All right, 5 steps to a note, a great critical care note. What are they critically ill with? I still examine the patients. Half my house staff don't even bother going into the room or examining the patients anymore. I actually examine them because I think it's good patient care and it helps me remember who they are and what's wrong with them. Have your notes say, what was your service? You don't need to say that you didn't overlap with anyone else, but when you do overlap, it's nice to say you had a mutual discussion about the patient. And of course, you have to have your time. And we've now got time for lots of questions in the few minutes remaining, although we've taken many along. I know you want to talk a little bit about advanced practitioners, so I'm going to stop sharing.
Oh, Scott, we can always arrange it for a different follow-up talk, but just want to make sure we give opportunity for others to ask questions now. But
yes, definitely. Definitely. Please ask questions. If somebody wants to start off with an advanced practitioner question, I'm happy, or I can just start talking. But
yeah, I agree with
we can make that happen, Lynn. Thanks for the comment in the chat there.
Yeah, this has been an amazing presentation, Scott. I know there are a lot of questions from a lot of people. People I know had to drop off at the 1 hour benchmark. But I did want to say that there are other topical areas that you had graciously, agreed to talk, which is one is the APP and split billing. The others is focusing on the outpatient side as well. And we eagerly look forward to those as a sequence. I did want to say that the intent here was to have sufficient interruptions and questions, which we did. But the idea is for us to be able to have the division chiefs distributed to the division members. And so we kept the group smaller. So there'll be more questions, I'm sure, that'll be coming at the next meetings, but also based on the viewership of these videos in respective divisions across the nation. So, but I wanted to be the first to really sincerely thank you, Scott, for an amazing presentation. I learned a lot personally, and feel like I'm better equipped to guide the faculty in our division, and I hope others feel the same. I will let Nizar bring it to a close, and I'm sure Lauren may have some additional questions. All of this is being recorded so that it can be transmitted. Nizar.
Yeah, so thanks again, Sai, for leading the development of this program, and thank you very, very much, Scott, for a fantastic, very informative presentation. I just want to let again, those of you, I think we'll also probably include it in an email that the executive committee is really working on a various initiative. This is the first one of the coding and billing, but we are also working on other things, including coaching, the summit in May at ATS, benchmark and compensation, and FTE, and an overriding, basically helping our division leaders manage the division, but also inspire and lead. And another thing that we're trying to do is really forge a closer connection between our division director association and the executive leadership of ATS, so that we make sure that we're in lockstep as we go through the year. With that, I just want to thank all of you. Any other last minute?
And thank you again for the invitation. I really enjoyed giving the talk and seeing a lot of old friends.
Yeah, I wanted to make sure Lauren didn't have anything additional to add to what you said, Nizar.
Yes, so I don't know whether Lauren is able to get back again.
I'm right here. Nothing to further add. Thank you so much to everybody. This was wonderful, and I appreciate it on behalf of the ATS for all of the insight and wisdom today.
And
excellent.
We'll circle back with you, Scott. Much appreciated.
You're welcome. Everybody stay well. Bye-bye.
Thank you, everyone, and happy holidays.
Yes.